Diaphragm, presented by Dr. Mary Maish. Please welcome back Dr. Maish.
Okay, when I do this part, I always tell everybody, okay, there's a lot of you in here who do hiatal hernia repairs and paraesophageal hernia repairs, and we all sort of finesse our way into determining how we're going to approach each patient, right? And that has evolved a lot over the last 30 years. So some of what I tell you today, you're going to be like, oh, I would never do that. So I probably wouldn't either, okay? But so it's just sort of remembering that a lot of what we do is still not very much driven by the literature, right? It's a lot of technique-driven things, a little bit driven by industry, we all have to sort of admit, right? If somebody comes out with a new mesh, you want to try it, see how it works, So when we talk about repairs of paraesophageal hernias, we just have to sort of look a little bit or try to remember a little bit of sort of take away some of the things that we do on everyday practice and just sort of remember a little bit about how, the traditions of it all came about and why we still think along those lines but change techniques a little bit to match modern day. So if it doesn't sit quite right with you, I've done my job. So hopefully you'll remember that when you take your exam. Okay, we're going to talk about the anatomy of the diaphragm, the physiology of the diaphragm very briefly. Then we'll talk quite a bit about the hernias, a little bit about eventration, because again, that's something we hardly ever see, but I'm sure you're going to see it, congenital hernias, and then some tumors of the diaphragm, which are rare, but at least just to understand sort of an approach of how you might resect them. Question. Paralyzing one hemidiaphragm only affects respiratory physiology. A, it will always affect respiratory physiology. B, only if it is due to tumor causing anatomic changes. C, only if a patient is spontaneously ventilating. Or D, only if a patient is on mechanical ventilation. Right, the answer is A, it will always affect respiratory physiology. The diaphragm is meant to move in tandem, and if it can't, then you can see changes in your respiratory physiology. So just as an overview, remembering that it is a skeletal muscle, it's actually two separate muscles that are brought together by a fibrinous central tendon. So I always sort of, if you think about it as a little bit of like two trampolines that are linked together by a little flexible bridge, one part of the trampoline will be affected by the other as that central tendon kind of gets moved around in the middle. And sometimes it can be actually very dramatic. So the muscles work in tandem to not only help with expansion of the side that they're on, but also with helping expansion of the side that they're not on, the contralateral side. The insertions are quite complicated. They change in all three dimensions in just about every aspect of the diameter of the muscle, and really are only important from the standpoint of resection. I mean, if you don't have to reconstruct or resect, then it doesn't really matter. But sometimes it can be very difficult to sort of sew meshes or repair the diaphragm on the ribs or even by the central tendon. And then finally, to remember, there are three esophageal hiatuses. There's the hiatus for the IVC, and then the hiatus for the esophagus, and then a separate hiatus for the aorta. And a lot of people think that it's only one hiatus, but actually there's a thin layer of tissue between the esophagus and the aorta, which we just go one fell swoop. And it's there to keep it separated, but generally it's three separate hiatuses. Okay, we're going to start a little bit about the physiology. We use our diaphragms as when the muscles contract to actually allow the air to rush into our lungs. So it's not sort of a drawing in; it's a creation of this intrathoracic pressure to allow the air to be rushed into the lungs and fill up those lung spaces. And on the flip side of that, when we have relaxation, then it's passive flow of the air. So the work of the diaphragm is all in bringing the air in. And so that's why when you see patients that have difficulty with their diaphragms, They often, talk about they have a little bit of this air hunger if their diaphragm is paralyzed, because they can't get enough of that air to sort of rush in. They don't have other problems with, shortness of breath in a more usual fashion, where somebody who has like decreased lung volumes, let's say from a lung resection, they're not going to feel as much of that air hunger because the rest of their air is being rushed in. And it's that feeling of that rushing in of air that makes us feel like our lungs are filling to capacity, even if we have a diminished capacity. So it's quite a different presentation of symptoms than in patients who had lung resections or diminished capacity from some other surgical issue. Symmetry, like we talked about, is very necessary for good function because they are kind of tied together in the middle of each other. Moving on to hernias. What differentiates a type 2 from a type 3 paraesophageal hernia? A type 2, the lower esophageal sphincter is fixed in the abdomen. B, the hernia is sliding. C, the lower esophageal sphincter and the stomach are above the GE junction. D, visceral organs are seen in the chest on a type 3 paraesophageal hernia. So the answer is A. A type 2, you're going to see that the lower esophageal sphincter remains fixed in the abdomen, whereas on a type 3, the sphincter itself is already, up inside the chest cavity. Next question. The workup of a paraesophageal hernia should include A, an upper GI only, B, a pH and manometry study, C, a pH and upper GI study, D, an upper GI and a manometry study. And I'm sure those of you that don't do this are looking at that and going, ugh. The answer is the upper GI and manometry study. And we'll talk a little bit about why that is. And then the last question, what two preoperative factors determine the surgical approach in the repair of a paraesophageal hernia? A, the size of the hiatal hernia and the body habitus of the patient. B, previous abdominal surgery and pulmonary reserve. C, position of the lower esophageal sphincter from the diaphragmatic hiatus and the percentage of the stomach and the chest. D, the position of the lower esophageal sphincter from the diaphragmatic hiatus and previous chest surgery. And the answer is position of the lower esophageal sphincter from the diaphragmatic hiatus and evaluating the percentage of the stomach in the chest. So paraesophageal hernias, the true paraesophageal hernia is really the type 2 because the esophagus remains in its normal anatomic position with the lower esophageal sphincter in the abdomen, and then the stomach slides up alongside of, or para, to the esophagus through the diaphragmatic hiatus. That's the true paraesophageal hernia, but we've classified all these other esophageal hernias sort of using that as the reference point. So a type 1 is our garden variety sliding hiatal hernia. That's where the GE junction is bouncing up and down into the chest and then back down into the abdomen. It's a little bit of a misnomer, right? Because there really is no sliding of the fundus of the stomach alongside of the esophagus. It kind of just comes up underneath the stomach, underneath the esophagus. So it kind of goes up and down like this. It's not sliding alongside, but it is still classified as a type 1 paraesophageal hernia. A type 2, again, the esophagus comes all the way down. The GE junction remains fixed in the abdomen, and that fundus comes up alongside of the stomach. So in a type 3, you still get that stomach sliding up alongside the esophagus. So it truly is paraesophageal. But the difference is that the sphincter is now up into the chest. And it doesn't slide. It stays up in the chest. So everything is kind of herniated up there. And finally, a type 4 is where you just have this big, gigantic, wide open hiatus, and you might have pancreas or, liver or whatever sliding up in there. This gives you a good schema of taking a look at what's normal, which is there on the left. And then in the middle here, you can see this is a sliding where sometimes the fundus is up above the diaphragm and other times it's down below. So that would be sliding. And this is the true type 2 paraesophageal, where the sphincter remains below the diaphragm, but the stomach is herniating alongside of it. So how do we evaluate these patients? Many of them come in with no symptoms at all. So it's very difficult to evaluate them based on their symptoms. Some of them come in with reflux-related symptoms, regurgitation. Other people present first time with like an episode of pneumonia or bronchitis. Many times they're elderly patients that have had these sliding hiatal hernias for many years of their life that have progressed then to a paraesophageal hernia. A barium swallow is a really good place to start because it can help you define the static anatomy and the dynamic anatomy. So if you've got a good radiologist that knows what they're doing, they can help you identify whether or not that lower esophageal sphincter is sliding. It can also help you identify how much of that stomach is in the chest if it's really done well. It can give you a little bit of evaluation of the contraction of the esophagus, so it can give you quite a bit of information. It's not great for everything, though, right? You can get a CT scan is going to help you identify if you have other abdominal contents, which you can't see that on a barium swallow. A motility study is essential for determining how much squeeze you have in your esophagus, so you know whether or not you're going to proceed with doing any kind of a fundoplication on these patients. And then, generally speaking, a pH probe is not indicated. You generally don't need that. And the only time I ever get that is in somebody who has really horrible heartburn, because then I'm going to want to know if they have really high levels of acid, so their Demeester score is like off the charts, then I'm probably going to make sure I do a really tight wrap. I won't offer anything else to them. I'll just, recommend a Nissen fundoplication. We also have to have an understanding and consider all the different ways to approach it. So we can approach this through the chest or through the abdomen. We can do it videoscopically, or we can do it open. We may offer a mesh as, generally speaking, not as a primary repair. We try always to primarily repair, but just like with any other hernia defect, right? We try to primarily repair it and then buttress it with a mesh, as opposed to just slap a mesh on there and not pulling those primary tissues together. But again, sometimes it's not possible, in which case you have to repair it with a mesh. We have to decide whether or not a fundoplication is going to be necessary, and if so, are we doing a full fundoplication or just a partial fundoplication? And then finally, are we going to peg this patient in order to help fix the stomach back down into the abdomen, and also help with some complications postoperatively? So I came up with this little pre-surgical checklist in my head. First, what's the type of the hernia? Second, where is it? How much of the stomach is in the chest? Third, do they even have any symptoms of reflux? And you should look at their motility. Fourth, how long has it been there? If it's been there a very, very long time, you're going to counsel them preoperatively differently than if it hasn't been. And lastly, what is the condition of the patient? The age is also a little bit of a factor to help you understand whether or not mesh might be necessary, so you can be prepared before you go to the OR, but mostly the condition of the patient. So you first taking a look at the type of hernia. Generally speaking, type 1 sliding hiatal hernias, patients are presenting with reflux. Those are going to be fixed laparoscopically, through the abdomen. Type 2s, same thing. Almost never do you have to go into the chest to repair a type 2. Type 3s, starting to get a little iffy. Many of these patients can be repaired through the abdomen, but very large paraesophageal hernias where more than 50% of the stomach is in the chest, you better start looking at your skills. Can you really reduce that hernia, get that esophagus as long as possible, and strip that pleural membrane to allow full re-expansion of that lung? Or are you just going to be just pulling it down and doing the patient a disservice because they'll be back for a redo in 2 years? Got to think about it for a type 3 and definitely for a type 4. If you've got a bunch of abdominal contents in your chest, you're going to want to carefully take down all of those adhesions in the chest before you shove it all back down there, and leave a bunch of stool up there or create a lot of bleeding, right? So definitely going to want to do those through the chest. Second, where is that lower esophageal sphincter? Is it 5 centimeters above the hiatus? If it is, you're going to be easily able to grab that down. Is it 7 centimeters? Maybe not so much. It depends, it depends on how facile you are. So traditionally speaking, we say if you don't do a lot of these, the safest thing, if it's more than 7 centimeters above the hiatus, that you should approach this through the chest. Now, I know many of us do it anyway, but for the safety of the boards, right, you want to think about, well, what could the average person do who doesn't do this all the time? 7 centimeters or more, you should be thinking about repairing this in the chest. And then there's other things to consider. How much of the stomach is in the chest also, just like we talked about. So if it's less than 5 centimeters or less, definitely through the abdomen. 7 centimeters or greater, start thinking about repairing it through the chest. Then how much stomach is in the chest? 50% of the stomach in the chest, it's going to be hard to do a really good reduction of that hernia sac. It's hard. It's very hard. And if you don't do it all the time, you're probably going to either leave hernia sac behind, bag the vagus nerve, injure some major blood vessel and get into bleeding. So, the safest thing is to repair a large type 3 with more than 50%. The safest thing is to do it through the chest. Third, does the patient have any reflux symptoms at all? If not, you don't need to get a pH probe, and you probably don't even need to wrap them. Okay, you can just pull it down and fix the stomach, and you're done. If you have any question at all, get a pH study on them, and then you'll kind of know how bad their reflux is and whether or not you're going to want to do a wrap on them. Regardless, you're going to want to get a manometry, right? You want to know whether or not that esophagus is going to be strong enough to undergo a wrap. So if you're thinking about doing a wrap, get a manometry. If you're not sure, if you definitely know you're not going to do a wrap, then you don't need to get a manometry study, okay? But in the patients that are being presented that have, any degree of heartburn or typical or atypical symptoms, get manometry because you're probably going to wrap those patients. Fourth, how long has it been there? Again, the longer that it's been, the more likely you're going to have dense adhesions, a thick hernia sac, and more contents up in the chest, the more likely you're going to have to approach this through the chest. The age of the patient, generally speaking, primary repairs on people, at the age of 50 or less, you don't want to try to have to put mesh. After the age of 70, probably doesn't matter. You put mesh or you don't put mesh, probably doesn't matter so much. But, you're going to evaluate their career at the time of surgery and determine what you're going to do. But in that critical age group, between 50 and 70, you're going to want to think about whether or not they have strong enough tissue to hold your repair for a lifetime repair, right? Older than 70, if it doesn't last a lifetime, average age of a person, is what, 74 and 76 or 78 or whatever it is. So your repair is probably going to hold out no matter what. But in that 50 to 70 age group, if it's a large paraesophageal hernia and your diaphragmatic defect is very big and you have a hard time closing that hiatus, you're either going to want to try to do a little bit of a relaxing incision on the diaphragm and bring the hiatus together nicely, or you're going to need to buttress it with some mesh. Then you want to look at the patient's condition. If they're debilitated, just peg them, reduce it and peg them. If they're deconditioned, you might want to consider doing more than just a peg tube. And if they're edentulous and they're not eating, then obviously peg tube is fine. You have to worry about them having bad reflux. Okay, so with these sort of things in mind, this little checklist that I put together for you, for myself, that I'm passing along to you, think about a couple of surgical scenarios. Again, this is not exactly what you might do in practice if you do these all the time. These are things that you need to think about from the standpoint if you don't do them all the time and the safe surgeon is going to do. 35-year-old with reflux, a type 1, so this sort of garden variety, right? The lower esophageal sphincter is within 5 centimeters. This patient's just an easy lap Nissen, right? Just no problems there. No mesh needed, no question as to whether or not they're going to need a wrap. They're going to need a wrap because they're young and they've got reflux. 50-year-old male with reflux, type 1 hernia. Now the hernia is a little higher, okay? The LES is 7 centimeters. Where are you going to do this guy? Think about doing it through the chest, right? Evaluate how much stomach is in the chest. If it's a type 1, generally speaking, because it's not true paraesophageal. Generally speaking, on a type 1, not that much stomach can get in the chest because, there's only a limited amount of space in which the stomach can get up there. But every once in a while, you'll see somebody with this gigantic, large type 1 hernia, and you think, well, maybe better repair that one through the chest. Are you going to put mesh? You're going to try not to, but, in a really, really obese person, you probably would need to reinforce that with mesh. And most likely you're going to do a full wrap in a patient that has known reflux disease. A 60-year-old with reflux disease, type 3, amplitudes on the manometry are a little bit low. That's why less than 60. And a lot of stomach is in the chest. Again, you might want to think about repairing this patient through the chest and either doing a partial wrap on them or just pegging them. You wouldn't want to put a full wrap because their amplitudes are pretty low, but they do have reflux disease. You probably want to do something for them, right? You're probably not going to want to do a peg. You think in your head, do they need a peg? No, probably not. Kind of young for a peg, right? Maybe just a partial wrap. 55-year-old male with reflux, a type 3, lots of stomach in the chest. That patient, again, you're going to want to think about whether or not there's enough stomach that warrants going into the chest. So I sort of use the 50% as a rule, rule of thumb. But again, these are not decisions made in a vacuum. They aren't going to just present you some super easy patient with just, BAMO, 50%. It's going to be sort of complex. You're going to put the nuances of the other things together to sort of push yourself into the chest category where normally in practice you might just be approaching it laparoscopically. And then finally, an older woman that's coming with a big type 4, most of those patients you're going to either not operate on at all, or if you think they can tolerate surgery and they're truly symptomatic, you're going to need to go into the chest to push everything down and then just peg them. Okay, so these are just a few scenarios to kind of help you figure out where going through the chest may be more necessary than what you might think of in regular everyday practice. Other diaphragmatic hernias. There's traumatic hernias and then there's congenital hernias. The traumatic hernias are generally discovered at the time of the trauma itself, but can be discovered later. So at the time of the trauma themselves, these can be repaired laparoscopically. It's, at the time that you're in there looking at other injuries, as long as those other injuries are controlled, you can go ahead and fix that diaphragmatic hernia at the same time. The critical thing in a traumatic hernia is just to make sure that there's no mention of any contamination before you slap a mesh on, because sometimes the defects can be pretty large. Otherwise, primarily repair it as best that you can. Attend to the other problems related to the contamination, and then come back and fix that patient at a later date once that infection is improved. And whether or not you go back through the abdomen or you go back through the chest depends on how large the hernia is at the time that you go back. So if you're trying to go back laparoscopically and you've got this big, gigantic diaphragmatic hernia that you kind of left behind at the time of the trauma, you're probably not going to get away with just going in there and reducing it laparoscopically. You're going to have to go in through the chest. So again, that's a little bit of a time frame thing. The longer you wait, the more likely you're going to have to go in through the chest. And there's no definitive time point, but I would say, in practice, generally it's about 3 months. After that, you're probably going to need to go into the chest to repair. Congenital hernias are a little bit different. I have a slide on that, and we'll talk about that in a little minute. It depends. There's really basically 2, and it depends on the location and how you manage those. Anytime you're repairing the diaphragm, whether it's related to a chronic or a traumatic injury, you want to try to pull it together, just like with any other hernia. You're going to try to pull that diaphragm together, and then if you're successful with no tension, you do not need to buttress it with any kind of patch. But even if you attempt to pull it together and you think that you're successful, slap a piece of mesh on top and reinforce that repair just in case your repair doesn't hold. If you have a larger defect, generally speaking, we say about 4 centimeters or greater, then you're probably not going to be able to repair that primarily. And you're going to need to interpose a piece of mesh in order to adequately close that diaphragm. Small holes over the top of the dome of the liver don't have to be repaired. They can be left open unless they're truly anterior, as in the case of one of the congenital hernias. But right over the dome of the liver, you can leave them behind. One of the technical points is we try to sew circumferentially on the diaphragm as opposed to right across the center of it, because that's where all the nerves are, and we're trying to preserve the phrenic nerve and the function. Okay, eventration. Question. Eventration of the diaphragm should be corrected even in the absence of symptoms if A, a patient is under the age of 70, B, it should only be repaired if symptomatic, C, infants under the age of 2, and D, only if there is damage to the phrenic nerve. Yeah, the answer is B, it should only be repaired if symptomatic. Eventration is a condition where the normal muscle fibers have been replaced by this fibroelastic tissue. So the diaphragm itself remains intact, but it becomes like a big anthill. And it still functions, but it doesn't function as well because now it's kind of floppy. Patients, generally speaking, present with a little bit of decline in their aggressive respiratory activities, so like when they're, out playing soccer or something like that. But otherwise, activities of daily living are almost never affected by it. The other thing is that when we fix it, we generally counsel patients that you're not going to, go back to Olympic status. So, patients have sort of this very unrealistic expectation that, hey, I'm going to get this fixed, and now I'm going to be this like class A, athlete. Yeah, that's not going to happen. But you have to be very careful in how you counsel them because they believe that that's going to be the case. Generally speaking, these are caused, most of the time they're just sort of congenital, but they can be in the sense that they are not born with them, but they do progress over time. But most of the time we find it from injury to the phrenic nerve, either traumatic injury or idiopathic injury from, a flu bug or a virus or something that we don't really understand. Indications are only for patients that have respiratory symptoms. Most of the time, epigastric pain is pretty nebulous. We say that if you have no other findings for your epigastric pain, it may be an indication for surgery, but it's a pretty soft indication. On occasion, patients can present with arrhythmias because a large portion of the abdominal contents are pushing up against the heart, but that's also pretty rare. The surgery is most often done through the chest. Generally speaking, we can do it all videoscopically. You just go in and plicate the diaphragm, and sometimes when it's very, very severe, you actually may have to put a piece of mesh over the top of your repair all along the edges of the diaphragmatic insertions in order to try to prevent that diaphragm from recurring in an eventration. So it can be very tricky sometimes to get a good result. Okay, and then lastly here, the congenital hernias. There are two types of hernias, the Morgagni, which occurs always on the right side, and it's anterior. Very easy to see. It's like a little sliver. Basically, the anterior portion of the diaphragm just doesn't quite reach the rib cage. Very easy to repair. You just slip a little piece of mesh in there. The only difficult spot is the medial spot where the central tendon is. Can be a little bit of a challenge to sew to, but it doesn't need to be repaired. It almost never causes life-threatening conditions. Patients often have it and never know they have symptoms. And then all of a sudden they find out that they have it and they're like, oh, I have all this shortness of breath that all of a sudden came on. Yeah, no, it's not due to that. But you can fix it anyway just because it can progress to, bowel getting trapped up there and strangulation. So generally in the active patient are the patients you're more likely going to want to control. Bach-to-lock hernias are rarely missed in infancy. They're for the pediatric surgeon to tell you about. So if he didn't, sorry about that. If he did, way to go. Otherwise, I would say that if they present in adulthood, they've gone through all the problems already related to resuscitation. So in the pediatric population, you're going to resuscitate them first and then take them for the repair of their Bach-to-lock. But in an adult, you don't have to worry about any of that. You just go and repair it. They're very difficult to repair because a large portion of the diaphragm is often gone, and the lung is often very atretic and unable to totally re-expand. So some people question even repairing these if they're found incidentally in adulthood, and reserve only for people that have had ongoing pulmonary infections and other related pulmonary conditions that may be affected, like lung cancer as an example. Somebody with a Bach-to-Lock hernia is found to have lung cancer. You may go in at the same time and repair both, but generally speaking, not such a common thing found in adulthood. Tumors of the diaphragm, there are mostly going to be related to tumors of the liver or tumors of the lung that are growing in. And these are considered direct extension tumors, which in both categories are all resectable. If it's big enough, you are going to have to place a mesh, just like you would for any other hole in the diaphragm, in along with the same principles that we talked about before. It's very unusual to have other primary tumors of the diaphragm, but by far the most common malignant tumor would be a sarcoma, and those are very rarely a primary source for the sarcoma, but in the event that they are, you need to resect the entire diaphragm, because in order to get on that side, because in order to get a good margin, there's not much diaphragm to take out anyway. So, even if you have a small tumor on the diaphragm, you're going to have to take out that whole hemidiaphragm and then reconstruct with a big piece of mesh. Okay, and I think that is it. So I can entertain some questions, and then I'll be around a little bit afterwards if there's other people that have any questions. So. Indications to repair a paraesophageal hernia. So for type 1s, because they're always associated with reflux disease, it's the same as the other lecture where we talked about reflux, like earlier in the lecture. So it's, looking at the symptoms of typical and atypical symptoms. It's looking at the Demeester score. It's looking at the motility. So that would be a type 1. A type 2, just the presence of a type 2 hernia is an indication, because they can strangulate. A type 3 is controversial, okay? So as surgeons, we always recommend repair. And the reason is a little bit based on old data, okay? But we still use it because we don't really have any better data. But we used to think that 20% of the time you could have torsion of the stomach and the chest leading to death, basically, right? So within 24 hours, you have a little nausea, boom, you're dead, okay? Actually, we know now that it's much less than that. It's about 4%. So to outright recommend surgery in every patient with a paraesophageal hernia, type 3 paraesophageal hernia that is completely asymptomatic, that's the data you have to present them. Well, you got a 4% chance of dying, if it strangulates. 4% chance of dying from strangulation, from torsion. So unless they're symptomatic, I generally don't recommend it. I'd say, well, you have to, almost everybody presents with shortness of breath, chest pain, heartburn, regurgitation, recurrent pneumonias, aspiration. It's pretty rare that you find somebody who's completely asymptomatic. If they were asymptomatic, I would present that data and look at their age and their condition and determine, but that's not a strong or a steadfast indication for the paraesophageal hernias. Any other question? Good. And I guess I've done my job. If you have any other questions, I'll be around for a little while, and feel free to email me at any time. Thank you.